Play on, DNA. This is your host, Kate Wilson, who knows absolutely nothing about soccer, but who does know genetics. We are talking to Dave Dubin, whose diagnosis with Lynch syndrome inspired him and his wife to start the nonprofit Alive and Kickin'. Lynch syndrome is a hereditary cancer syndrome that is associated with colorectal, endometrial, ovarian, stomach, and other cancers. Dave works with Alive and Kickin' to improve the lives of individuals and families affected by Lynch syndrome and associated cancers through research, education, and screening. We chat about colonoscopies, his son's undergoing genetic testing, and having cancer multiple times. Let's get started. Hi, Dave. Welcome to the show. I'm excited to have you on today.
Thanks for having me.
So glad you're here. Well, first off, I thought you could tell us about your foundation, Alive and Kickin', and why you started this foundation.
Sure. So the original name of Alive and Kicking comes from my love of the game of soccer, or as many would call football. So we actually, so my wife Robin and I started Alive and Kicking back in 2011. After my Lynch syndrome diagnosis, which I imagine we will be discussing, it was after my third cancer as well as the Lynch syndrome diagnosis. And the name seemed apropos for someone who had had a number of surgeries, a number of cancers, but yet still continued to, play the game he loved and keep keep a full schedule of activity. And it just kind of stuck. I originally had the idea of Dave's Not Dead Yet, and Robin did not appreciate that name, so we moved on to
Yeah.
Alive and Kicking, and I think it's probably better for the long run. But the reason we did it back then, and even to this day, is that um, in the advocacy space, again back then, we really did not see any advocacy organization that was focusing on Lynch syndrome. There were, of course, colon cancer organizations, and as there should be, and obviously breast cancer organizations. But we really didn't see an advocacy space, and that's why we did it. We felt incumbent, and we really did not know what Lynch syndrome was. Yeah, and as we go through my family history, you'll see, like, how did we not know this? And we felt the same way. That's how we felt incumbent to do this. If there wasn't a need, we wouldn't have done it. And to this point, there still is a very limited advocacy world for Lynch syndrome specifically. There's a handful of us. We all know each other and we all appreciate each other. But at the end of the day, given the numbers, and obviously we're going to be talking about that, we really there should be more, and we hope there will be more because it's warranted.
It definitely. And that was so 14 years ago, started the foundation. And then, like you said at that time, yeah, there was even less kind of awareness about it than we have today, but we're still trying to push awareness. And you talked about Lynch syndrome and colon cancer. So I think let's start with some basic information. Colon cancer. A lot of people have probably heard about it, but how do you tell somebody or explain what colon cancer is?
Have a lot of people heard of colon cancer? I'm going to say probably. I mean, if you really sit down with somebody and throw out the words colon cancer, they will probably be able to cite somebody in their family who probably had colon cancer at one time or other. It is I believe, the second most prevalent cancer out there. And I think it's either the third most prevalent and second most cancer killer, or vice versa. But we can look that up
Yeah, we
another
can look
another
that up.
time. But essentially, what typically happens in the colon cancer space is a polyp is created, and then over time it is essentially becomes cancerous if it is not removed. That's your typical colon cancer, which obviously takes place within the colon. Lynch syndrome is a different animal than regular colon cancer, so we can talk about that if you want. But that's essentially your typical scenario. It is, there are estimates that a polyp can take as much, several years to become cancerous, which is why you want to have regular screenings and of course, a colonoscopy in order to try and remove it at a time when it is precancerous, as we should, and then we can go back to normally screening regimens. So that's your standard colon cancer. And normal time frames for screening, 45. It was 50 previously, a number of years ago. Now it's been down to 45 as far as screening age, and there are a number of different modalities and that can screen for colon cancer, but that's essentially what it typically is.
Right, right. And that's one of the reasons people talk about doing colonoscopies, and that, you can remove the polyps before they become cancerous. So that's kind of the hope of doing some of the colonoscopy screenings. You mentioned with colon cancer, we talk about Lynch syndrome, and Lynch syndrome is something that's hereditary or an inherited one because you were talking about your family history. Most colon cancer is not hereditary, so not something that you get from your mom or your dad. It used to be, we would say in clinic, like 5 to 10% is hereditary. I don't know if that's still the same for colon cancer.
Well, I think definite number is a tough one
Yeah.
because we're you got to remember genetics is, as you know, is such a new field, and we're generating so much data on a daily basis that when we talk about statistics, some of them are going to be off. That's just how it is when you're dealing with statistics, and you're dealing with time frames. So it wasn't that long ago where people died of a stomach ache, and you're like, okay, you just throw your hands up and you move on. But now that we understand a lot more about cancer, we understand a lot more about genetics, and we're starting to put the pieces together. There are estimates that more cancers are hereditary, and we're not just talking about colon cancer, but in the instances of colon cancer, it is estimated still that 5 to 7% of all colon cancers are considered hereditary. If you want to look at the estimates reversely, or in a different way, it's estimated that 1 in 279 Americans has a Lynch syndrome mutation, and 95% don't know about it still, which is crazy. So there are guidelines now that anyone who develops a colon cancer under age 45 gets genetic testing.
Mhm.
There are also guidelines to steer people to have genetic testing, regardless of the age of, let's say, a colon cancer or a pancreatic cancer, something similar to that. So there's much more awareness. There's much more data being created. Statistically, will we continue to go up? My prediction is yes. There are studies out there where universal tumor screening was done in large populations, like it has been done with like this in Ohio with the Ohio State
Mhm.
and Memorial Sloan Kettering. And when they did these studies, they found a much higher percentage of colon cancers were considered hereditary. Lynch syndrome specifically, closer to the 15 to 17% range, which is obviously statistically significant. But again, we're just talking about a one section of the population. Getting it to scale is always another story.
Right, right. And so numbers can fluctuate. So, and we'll cite some of the reference papers in the show notes too that kind of go through some of the estimates. With hereditary colon cancer, we talk about Lynch syndrome a lot. There are multiple syndromes or conditions that are associated with hereditary colon cancer, Lynch being one of them. But I do think Lynch is probably one of the more common ones, or ones that maybe is seen more often. There are multiple genes associated with Lynch syndrome. So tell us about what Lynch syndrome is, what makes it different from, I would say, just your sporadic everyday type of colon cancer. Like why is Lynch syndrome different? Why is it important for some of these places to do this genetic testing or genetic screening?
Where do you start?
I know. I was like, that was a lot in one question.
Yeah, I got to unpack that one. Okay, so yes, you're correct. Lynch syndrome is multiple genes. They're considered mismatch repair genes. The other higher percentage mutation would be considered FAP, familial adenoma polyposis, and FAP presents itself significantly different. FAP is something along the lines where the person who has FAP, again, so I'll backtrack a little further because I think your listeners appreciate this. They're autosomal dominant. So you can share what that means. But both FAP and Lynch syndrome mutations are all considered autosomal dominant. So FAP, if you have that mutation, you're going to develop hundreds, if not thousands, of polyps very early on in your life, and the odds on getting colon cancer are essentially 100%. Okay, so that's FAP in itself. So it's not as prevalent, let's say, as Lynch syndrome. And again, pure speculation, is not a clinical person, probably because people didn't survive FAP over time. Because again, it is 100% chance of getting cancer. So let's pocket FAP. Concentrating, going back on Lynch, if you have a Lynch mutation, it does not guarantee you will get colon cancer or any other cancers. It just increases the percentages of a number of different types of colon cancers, cancers, typically in the digestive tract, the reproductive tract, urinary tract. Those are your Lynch mutations. That's your standard stuff. So your typical age, again, your the stereotype or traditional colorectal cancer time frame is 45 and older. That's again your typical, because polyps typically take several years to become cancerous. Okay, in Lynch syndrome, everything is moved up in time frame. So the best example I can give you is my own story, and which is one of the reasons why we did this. I was 29 when I had my first colon cancer. So again, if you have a mutation, again, depending on the mutation you have, that'll determine the percentages, again, based upon current data, of how early you should be screened for certain types of cancers, and the statistics of having them happen. Again, so my mutation is an MLH1 mutation, which typically has as much as an 80% chance of developing colorectal cancer in your lifetime, usually at a younger age than most. Okay, usually. You unpack that and you say, okay, 80%, it's not 100%, but it's a high percentage. Is it going to happen earlier? Is it going to happen at all? Maybe, maybe not. Is it going to happen earlier than age 45? Maybe, maybe not. There are people and these are the type of studies that we're doing now, is you can have an entire family, each with, and let's say there's 3, 2, 4, whatever the number is in that family, and that may have the mutation. Some will get a cancer at an earlier age, some will get a cancer at a later age, and then there are some that don't develop cancer at all. So I want to emphasize that there are no guarantees in this case. FAP, different story. It's 100%.
Mhm. But with Lynch, it's increased risk for certain types of cancers, but it doesn't necessarily mean that a person will definitely get it, but it does mean that they have this increased risk for certain cancers.
Correct, and it is different, obviously, male versus female, because women do have the reproductive tract that they have to be aware of, because it does affect your gynecological cancers, specifically endometrial cancer, as well as potentially ovarian cancer.
Lynch syndrome. So you talked about digestive tract, colon cancer, also increased risk for certain reproductive cancers like endometrial or uterine and ovarian. In finding out that somebody has Lynch syndrome, what types of screenings change, or how do these types of screenings change for somebody who has Lynch syndrome?
So depending on and some of this obviously will depend upon geography, how aggressive you may have a coach who or an oncologist or a genetic counselor or your gastroenterologist or your OBGYN. These anyone or all of these can be your coaches once you know you have a mutation, right? So that's my emphasis out of all this is if you know you have a mutation, then you can be proactive in your screening. If you don't know you have mutation, you're not necessarily looking for all these things. You consider yourself, especially men, fine. Men don't go for screening for anything, let alone genetic testing and colorectal cancer screening. But which has kind of made me unique. Which is
Well, I was going to say, so how did you find out you had Lynch syndrome, since it is something that is not always routinely tested for?
so I found out, again. My first cancer was at age 29. My father had had colon cancer before me. He was in his 40s when he had his first colon cancer. My grandfather had colon cancer before him. He was in his 60s. Both of them had lived well into their 80s. They almost reached their 90th birthday, and multiple cancers and whatnot. I had my second colon cancer at age 40, so it was 10 years apart. And it was, if you want to do the timeline on this, the second colon cancer was in 2007. So you look at and so the first time, 1997, I had symptoms. I had your traditional symptoms of colon cancer: blood in the stool, cramping. I was not lethargic. Again, I was 29 years old. I was still playing soccer. I was still running the business, and yeah, it wasn't until I had my colon cancer at 29. Had my surgery. It was almost like a rite of passage, to be honest with you.
Hmm.
And then 10 years later, after having an annual colonoscopy, barely 13 months previous, which was clear, I go to donate blood, like on
Hmm.
purpose, and my iron count had dropped like a stone. They were going to give me a transfusion. It was wild, and I had no symptoms. I was, again, still playing. When you turn 40, you're supposed to get tired when you play. You're no longer, what you used to be. And sure enough, I had stage 2 colon cancer, and I had
Wow.
no symptoms whatsoever. So,
Wow.
as no good deed goes unpunished. And I have I go back to my GI doctor, and by now we've been together for many years. We have genetic testing done. And that's how I found out about it, because now, 2007, people are talking about genetics. And yeah, as much as really it goes back to Henry Lynch back in the 1980s,
Hmm.
really wasn't until the early 2000s when anybody was doing much about it. And that was really the cusp of the genetic testing. I don't want to call it the revolution, but really when it started becoming more and more prevalent. Next generation sequencing had not been really invented yet,
Right.
but you were doing genetic testing because you knew more.
Right. And it was your doctor that approached you or mentioned the genetic testing, or was it something that you found out and asked your doctor about?
Well, it's, oh goodness. I mean, it's hard to remember at this point.
Hmm.
I'm pretty well. First of all, when it happened and the way that it happened, it set off so many bells, right?
Hmm.
To go from a clear colonoscopy to stage 2 colon cancer in 13 months
Right.
without any symptoms. Again, you talk about what I talked about earlier with a polyp phase, going from a polyp to cancerous over years. Obviously, I'm an overachiever. So now you look at this and you're like, okay, we went from theoretically 0 to stage 2 in 13 months, probably less if you really think about it. If I hadn't gone to the blood center to donate blood, who knows how long I could have let it go. I mean, we were
Right.
all human. I mean, it's like muscle memory. You start losing memory. Once I had my colon cancer, I'm like, I'm done.
Yeah.
And then you start spacing your your colonoscopy screening. Yeah, maybe 13 months, 15 months, 18 months. This one was 13 months,
Yeah.
and like, I would use the term "holy crap," but that might be inapplicable here. But
It's fine.
so when that happened, again, I had my second surgery. We talked about the idea. So again, I don't remember whether he brought it up or is my surgeon, but so Mount Sinai Hospital has been my home away from home since '97. So you
Hmm.
can do the math on that. The At the time, there were very few genetic counselors, right?
Hmm.
So Karen Brown, 100 years ago, started the department, and there was like one or two people, and they weren't that busy yet. I could literally walk down the proverbial hall and meet with a genetic counselor, and they can go through the map and show the pedigree and say, all right, this father, grandfather, brother, dog, goldfish, and then you have your math there, and that's when they recommend it. And so first thing first was, we're going to have surgery to get this thing out. Second thing is, we're going to send a tube of blood off into the netherworld, and we're going to hopefully get an answer in 3 months.
Oh,
Three
wow.
months. Remember
Wow.
that?
That's
Right.
definitely changed.
And because back in the day, you were sequencing like one mutation at a time, or maybe
Right.
five. Like in the case of Lynch, there's five. If you were doing BRCA 1 or 2, okay, but you didn't have panels. Remember those days?
Yep.
I'm sorry, I'm dating myself. I didn't mean to throw that on
No,
you, but you
I'm
get my
gonna
point.
yeah. No, I started during the era of Sanger sequencing, and so things
Right.
took a lot longer and were much more expensive.
It was like 25 grand for one gene.
Yeah.
And I mean, I was, so thankfully I had good insurance, and that was never an issue, and have my surgery, and I'm again fine, if you will. And, I get a call, and they're like, we got your results. And we knew what it was going to be, but there it is. And all right, what do you do now? And then the genetic counselors said, well, it's more than just colon cancer. It has potential, like I just said with you.
Right.
And I'm like, so what do I do? They're like, well, you should probably get an oncologist. I'm like, ugh, 40 years old. I get an oncologist. Right. So who wants that? Right.
Right.
Uh, Especially a guy, or, as I say, I used to be a guy. Now I'm a man. But, I get an oncologist, and they're like, well, it has all these other things. We're going to do baseline CTs, chest, abdomen, and pelvis. We're going to do an MRCP, check the pancreas. We're going to do, you want to get a cystoscopy to check the prostate and the bladder. I'm like, ugh.
I was gonna say, so how was that going from, okay, I've had colon cancer, like you said, at 29, rite of passage, kind of almost in your family because some other people had colon cancer, to then learn like, okay, now you have Lynch syndrome, and this means we have to do this checklist of stuff.
Well, it wasn't just that. The big issue is that we now had three kids. We had the three boys by then. So,
Hmm.
I'm and I say this all the time because it's actually true. Is in the advocacy space, and you hear people talking about their genetic test. Had they known about their mutation, they may not have had kids. And I just listened to him say it, and I'm like, you probably have your kid in the other room while you're saying this. You really. Mm. I don't feel that way, and I can't turn back time, so I'm not going to try. I will say this though: I did not know about we, and obviously Robin and I are included in this. We did not know about my mutation until after all three kids were born.
Hmm.
They've only known me as a survivor. They're not afraid of it, and we can talk about where they are in this journey now. But now it means more than just colon cancer, and it means more than just me. It's now the boys, and that's where everything kind of changed. Not kind of, everything really did change when that happened. When that level of information was now available to us, and it was up to us to make the most of it, and that's how we approached it, and so far so good.
Well, good. I mean, I'm glad so far so good. With Lynch syndrome, for the audience, it's what we call an autosomal dominant condition, which means that if you have this condition, there's a 50-50 chance that you'll pass it along or pass that gene mutation to your children,
To each child.
to each child. So each
Yep.
child has a 50-50 chance of also having the same
Correct.
MLH1 mutation that you have.
Yep.
I guess tell us what that has been like, like you said, you found out, but it was after you had kids. What has that been like, talking to them about it or chatting with them about screening? Should they have testing or not have testing? How have you guys handled that conversation?
So I always talk about this, and I always say that I'm different. And when I say I'm different, we're different. I guess. So when I say I'm including Robin, and I'll apologize for not saying we each time. Um, we're different in that we started a foundation. We started Alive and Kicking. When that happened, for whatever reason, there was a level of comfort in having me do public speaking. I was comfortable with it, and Cancer Center leadership was comfortable doing that as well. So I was out there, and I started getting involved with a lot of things. I was involved with colon cancer advocacy. I was walking the hill. I was doing public speaking engagements, whether it was colon cancer awareness day, now Lynch syndrome awareness day. You get my point.
Hmm.
So we were putting stuff out there, and the boys, of course, saw it.
Right.
And again, as much as they were younger then, they got older as time went on. This started back in 2011. We're now in whatever year we're in now, 1939, and the so they saw what was taking place from our standpoint. They saw that we were comfortable with this. They saw that we were very public about what was going on, and that people were looking to us for information. So they saw all this,
Hmm.
and as time went on, they would have conversations with us. They would ask questions. Can I inherit this? Your your questions that are any kid would ask, like, if I get this, am I going to die? And I would, the answer would be, well, I haven't died yet either. I mean, I can get on the New Jersey Turnpike and get mowed down by a semi. That's part of life. But
Hmm.
statistically, when you look at what's going on with from a Lynch syndrome standpoint, by knowing what we have going on, we can be very proactive. And of course, as time has gone on and I've aged, I'm seeing guys who have heart attacks, you know, and my oncologist would say this all the time. More people die of cardiovascular issues than all cancers combined. So, it puts things in perspective. And because of that, there was a comfort level. Now, when it came to genetic testing, because this is where a lot of the question comes into us, is that when do you get your kids
Hmm.
tested? So
Right.
we, of course, cannot tell you what to do, but for the most part, Lynch syndrome has been shown to be a adult onset syndrome. So typically, unless both parents have a mutation, and we can talk about that if you want, typically you're not going to have a cancer before you turn age 18. So we have recommended to our own children, and we recommended to others, that wait until they turn 18, and that way it's their decision. They do the consenting. They feel empowered by doing so, and they're more comfortable with the results. Again, stipulating that we never had a inkling that the boys would not follow through, because once they turn 18, it is their decision.
Right.
The proverbial cat will be out of the bag at that point. If they don't do it, you can't force it. We did that, and in turn, each had their genetic testing when they turned 18, and again, it's so far so good as far as their comfort level with it. And if you want, I can share how, who was positive and who was negative if you want.
Well, and I don't necessarily know if you need to share, who is positive and negative, but it sounds like they're in some of your kids probably tested positive, some probably tested negative. Do you find that made a difference in them keeping up with their health, or are they still? Well, let me think how I want to rephrase this.
I'll save you the trouble to say it's public. So 2 out of 3 are positive. So oldest is positive, youngest is positive, middle is negative, and we don't actually use their names. They're just known. They're boys. They're Dubin, so they're oldest,
Hmm.
middle, and youngest. That's their actual names at this point. They have been. We kind of go to our screenings together. Um, we make sure that, if we're having our colonoscopies on the same day with the same GI doctor, that he does in fact clean the instruments in between,
Jeez.
or at least give us different rooms. But yeah, they've been interviewed, so there's a comfort level there, and they're okay with it.
We talked about with genetic testing and doing blood work. So you mentioned your blood work. You mentioned that your boys, when they were old enough, they had samples sent in for testing. But there is other types of genetic testing or screening that can be done for Lynch syndrome, in terms of like tissue testing. So like when somebody has a polyp or cancer removed, are there certain types of tests or screening that's done to say, okay, you're somebody that is a candidate for genetic testing? Because there are certain changes that you can see on tumor tissue that make you more suspicious for Lynch syndrome.
Okay, so yes, in the case of Lynch syndrome, the hallmark of Lynch cancers is what's considered microsatellite instability. So this was something that was discovered again back in the 80s, I believe, and really has become much more of a topic again because of genetic testing and the amount of data and information that's now available to us. So again, 100 years ago, when I had my first cancer, we weren't doing tissue testing. It was just get this thing out and throw 5FU chemotherapy at it and hope for the best. That's to an extent. 5FU has been proven now for Lynch cancers and MSI high that doesn't do anything. It's just a waste of everybody's time and made you feel miserable. But I'm not. Again, you can't turn back time, so we move on.
Right.
So let's say, for argument's sake, I had my another cancer now, and it was a stage 3B, or God forbid stage 4. Have it taken out. You would test the tissue for a number of things, including what would be considered microsatellite instability. So MSI high, microsatellite unstable high, is the hallmark of Lynch cancers. This allows you to, if you're MSI high or MSI normal, depending on and any number of types of genetic markers that you're tested for, again, because we're talking about major panels now, that'll determine the best route for you moving forward. So immunotherapy has been proven to be very effective for patients with MSI high tumors. So let's just specifically talk about Lynch because obviously I'm biased. So if you have MSI high, there are immunotherapy drugs that are now FDA approved for those tumors, regardless of where they are in your body. So I think actually I may have left this out is that dermatology. So Lynch is also has basal cell carcinomas. No, squamous carcinomas.
Mhm.
So you should also have your skin check on an annual basis. So if I left that out, I apologize. But if you have, let's say, a skin cancer or a pancreatic cancer or a endometrial cancer or a colon cancer, you can test all of these with a broad panel, and depending on what your biomarker comes back as, that can determine the best route for your treatment. It may be, and I don't want to go out on a limb here, but I do believe there are some immunotherapies that are now either in process of being FDA approved for first line, or already are. I don't want to muddy the water on that. But you can have an immunotherapy and have really good effects in terms of getting rid of that cancer, sometimes even before surgery.
Mhm.
So
Mhm.
it again, you just for an overall theme, the knowledge is going to be more powerful. And I don't want to get too far down the line and get over his skis, but there are now vaccines in process in phase one
Mhm.
for again MSI. So how do I say this? It's a strange way to think about it, but I feel a level of fortune that MSI high runs along with Lynch syndrome because I'm again going over time, having been in the advocacy space so long now, because I'm going on almost 30 years now of doing this. The foundation is as much as 2011, but being a survivor for almost 30 years, you see a lot of people pass away. I will say that a significant percentage, I'm not going to say majority, that's because that's wrong, and all this is anecdotal, is that those who know they have a mutation like a Lynch syndrome ahead of time have really good outcomes moving forward. It's those that really don't know what's going on in their bodies that they get hit in the face with the frying pan, and sometimes it's tough to recover. And yeah, that's the best way I can put it.
Mhm. And why do you think that not many people are being tested? Or I think you had said something about a certain number of folks that have Lynch syndrome aren't even aware that they have it. So why do you think we're not finding everyone that has Lynch syndrome?
Well, I think as a society, we're not great on really being proactive and preventing things. So we can start there. Secondly, is you look at information again. Electronic medical records are relatively new. They weren't necessarily designed for providing information. They were designed for financials, for health systems. So they were designed to enable doctors to get paid. Nothing wrong with it, but they have to evolve. So now we're starting to see the evolution of much more of an information system. Hopefully, it continues. If you have essentially a society, especially on the male side, that really doesn't talk about being proactive and being preventative, they're not really thinking about stuff. They're thinking about what they're thinking about their day to day jobs. They're thinking about things that are very transactional in their lives. They're not thinking that far ahead. And to an extent, let's be honest, having a genetic test or having something like this, what did it mean?
Right.
Was there something that could be done about it? And in some cases, yes, but in some cases, no. Everyone brings up Huntington's disease, and it bothers me that it happens, but everyone brings it up. If Huntington's disease runs in your family, again, you have a 50-50 chance of inheriting it. And if you do inherit it, you are going to die of it at a young age. And it's going to be awful. I've seen it. And it is. So people don't get tested for it because what are they going to do? Are they
There's not
going to
a treatment or a prevention for it.
right? So now let's just again going back to Lynch, there are treatments, there's screenings, there's treatments, there's a potential vaccine. So knowing this should should change the paradigm. I'm hopeful that it will, and that's why I do what I do.
And if somebody is concerned about Lynch syndrome, or maybe, they have a family history of colon cancer, do you have any advice on how they can talk to their doctor or find genetic testing if they want to do it?
Sure. The answer is it's so much more of a conversation piece now that you should be able to have your conversation, whether it's your primary care physician, your gastroenterologist, your OB. I think having been in this space for a while now, like you, is I think the OBs have the best opportunity for moving the needle because women are much more proactive in their care, and obviously you're going to the OB for a reason, and you're having other types of screenings done, genetic testing in the prenatal space. So this is a type of conversation you can have with a patient and their spouse potentially about this. I think that's an opportunity. Genetic counselors, obviously, best conversation because they are very knowledgeable and they do know the statistics. But some of the issues are, some of the issues with genetic counselors that there aren't as many of them around the country by
Hmm.
far compared to, let's say, an OB or a GI or a primary care physician. So they're not as easy to track down and get a half hour of time together with them. What often has happened now over the last, I would say, well, you tell me, maybe 6, 7 years, essentially, genetic counselors have gotten more involved with the conversation after genetic testing has been ordered. And you can stop me if I'm wrong. So what winds up happening is someone thinks they may have a history of cancer or whatever in their family, talks to their primary care physician, talks to their GI, talks to their OB. They say, "All right, maybe, but let's do this. Let's take some blood. We'll send it off to the netherworld. We'll get a result in what now? 7 days, 10 days, right? And it's a whole panel, and it costs $150. Again, going back to 30 years ago, it was significantly different, or 20 years ago. I've lost track of time. But so then if it comes back negative to an extent, you don't have to have a significant conversation. I mean, there's this, there are different models that say you might be at higher risk because of other things. But for the most part, it's a cut and dry answer unless it's a VUS, which we'll leave alone. So if you get tested for MLH1, come back negative, and you come back negative, a true negative on everything, there's not a lot. There's not as much to talk about. However, you test positive, now your genetic counselor can come in and say, all right, well, you tested positive for this mutation. Your family members have had this cancer, this cancer, this cancer. We should be screening you for these cancers, but of course, we should be screening you for these cancers as well. This is the statistics. Let's create your plan. Let's make your plan and implement that. And we're going to coach you along the way and make sure we find something, we find it early, or we don't find it, or it just doesn't happen. Too simple.
No, no. I think that that's a good way to summarize it. And the other thing that you bring up is if somebody in your family has a known mutation already, they test negative for that mutation, the terminology is a true negative, right? So for your son that tested negative, they know for sure they don't have Lynch syndrome, and they could do general population or the regular type of colon cancer screenings. They don't necessarily need extra screenings or earlier screenings.
Correct.
If a listener, walks away from the conversation, they're only going to remember hopefully one thing, maybe more. I always hope for more. But if there's one thing that they take away about Lynch syndrome or about Alive and Kickin', what is the one thing that you want them to take away?
Wow, one thing.
Yeah.
Now, shouldn't we have done this one thing in the beginning?
I
No.
also have some guests that like to slip in 2 to 3 things. So, it's not a hard and fast
Uh,
rule.
so genetic testing is information. That's the best thing. The best way I would put it is knowing your genetics, knowing your family history is information, and it allows you to make plans and make decisions. That's the best way I would put it. We, as an organization at Alive and Kickin', try and get the word out about Lynch syndrome, specifically about understanding what it means, what it doesn't mean. We try and do it in multiple languages and multiple facets so that it's absorbable to multiple populations, because it is not just the proverbial white male disease, which colon cancer has been stereotyped, which is also not true. So it can affect men, it can affect women, it can affect multiple ethnicities. We're all a bunch of mutts, and the more we know about our genetic makeup, the more we can be proactive in our care and really do something about something like this. And obviously, it is not a death sentence. I'm still here, as I like to say. I'm still alive and kicking, and like I said, I take my chances on the turnpike every day. So far, so good.
I think that's a excellent point to end on, and we'll definitely put a link to the Alive and Kickin' website in the show notes as well. And Dave, I really appreciate you being here. I appreciate you sharing your story with us today.
No, it's my pleasure. Thanks for having me.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Please rate and review the podcast on Apple, Spotify, YouTube, or wherever you listen. This helps other people like you discover the show. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. All Access DNA is an independent podcast hosted and produced by me, Kate Wilson. Designed by NKJ, created the logo. Thanks for listening, and join us next time.